I think that most people are like me, that they don't really get it. And we are doing things wrong. We are literally just guessing. And now there's this technology, there's this new specialty where I can look at the heart, where I can measure how the heart is working. And by using that tool, I can make more refined decisions for my patients.
Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals, like you, better understand, support, and nurture the entire NICU family. Howdy, everybody, and welcome back to another really great episode of NICU Heroes. This year is shaping up to be really fantastic. I am loving visiting with all these different specialists. So here's the thing that I'm finding to be true. Whether they are a specialist in a certain area, or they have a specific condition or diagnosis that they focus on, they are like super fans in that area. I have to admit, frankly, I was very nervous about interviewing a pediatric cardiologist who specialized in hemodynamics. First of all, hemodynamics is a hard word to say, but also it felt a little intimidating. One, because it is not a specialty that I had heard of. Our son has a couple of heart defects that have since been corrected, one just by time and patience, and the other one surgically. And so I felt like I knew enough about the heart to be just a little bit dangerous. And I had a great interview last year with the chief of pediatric cardiology at a children's hospital here in Texas and learned even more about the heart. But when it came to hemodynamics, I got to be honest, I was a little nervous. But what I found through my conversation with Dr. Bischoff is that, one, she's a super fan, but also she made it so engaging that I was looking at the clock and I was like, I'm going to have to stop asking her questions because I was so fascinated by what she can do, what she knows, and this new subspecialty that's sort of coming to the forefront. She's the very first fellow in the country in hemodynamics, which makes her a great expert to talk to. So I really hope that as a NICU professional at the bedside, that you take a lot away from this conversation. There's some things that we talk about specifically related to things that you can do at the bedside to be a better NICU professional with all those babies, and how what we're learning in heart conditions and how we treat them is advancing. So it's such an exciting trajectory. So I hope that you're as excited as I am about today's guest. My guest today is Dr. Adrianne Rahde Bischoff. She is the clinical assistant professor of pediatrics and a neonatal hemodynamic specialist at the University of Iowa. Adrianne did most of her medical training in her hometown in South Brazil before heading to Toronto for her neonatal perinatal fellowship, and then finally to Iowa to be the very first neonatal hemodynamics fellow in the country. Her research interests relate to the use of targeted neonatal echocardiography, cardiovascular physiology, and PDA closure. All things which I know that you have heard of before. She's a member of the Pan American Hemodynamics Collaborative, an academic consortium of neonatologists with hemodynamic expertise, which promotes educational initiatives in the field, and then it cultivates multi-center clinical research. She's also a council member of the Midwest Society for Pediatric Research. Her academic focus revolves around the intricacies of cardiovascular physiology. So how is the heart made up? And where her expertise really shines is in the aftermath of definitive PDA closure. She delves deeply into neonatal hemodynamics, unraveling complexities and implications within various disease states, significantly impacting the morbidity among this very vulnerable population of preterm and critically ill neonates. I know that you are going to learn a ton. So without further ado, let's get to it. I'm always excited to talk to someone who loves a specific organ And today we're talking a lot about the heart. And so I love, Dr. Bischoff, when you went into medical school, when you went into medicine, what what was the precursor? Like, why medicine? And then why the specialty of pediatric hemodynamics? I'm always fascinated to know.
I honestly have always wanted to be a doctor. I have a drawing from when I was in first grade that I drew myself as a doctor. I don't know if it's because I had doctors in the family and they were just kind of my inspiration, but I had the very cliche, I want to help people. I want to make sure that people are not getting sick. And that's why I went into medicine. And then, funny enough, I fell in love with neonatology before I fell in love with pediatrics. So pediatrics was just a means for me to get to neonatology. I loved the babies. I love intensive care. I loved seeing them being so tiny and then going home after, and that trajectory with them being super sick at one point and then learning how to eat and developing bonds with their families. So I fell in love with neonatology first. Had to do pediatrics in the middle of the wave because that was part of the deal. Had to go through the adolescent clinic and all the things that I could not care less about. I'm so glad that there are people who like it out there, but that was not for me. And then, funny enough, about the heart itself, I actually didn't like the heart in med school. I hated it. And I think it's because I didn't understand it.
Okay.
I don't think that my education was, I'm not going to say my education was not good. Obviously, it was good, but it just didn't click. It didn't click to me, that physiology. I thought it was really hard. I didn't quite get it. I was like, this is just too abstract. I don't like it. But then I did a course when I was still a neonatal pediatrics resident, actually, about ultrasound. And then I started seeing the heart, and then it started clicking. And I was like, oh, wow, I can make a difference, because I think that most people are like me, that they don't really get it. And we are doing things wrong. We are literally just guessing. And now there's this technology, there's this new specialty where I can look at the heart, where I can measure how the heart is working. And by using that tool, I can make more refined decisions for my patients. And that's kind of where that love for hemodynamics grew.
Well, I mean, the heart is not like a simple organ. I mean, it's kind of important. Everyone needs one. There are some organs like appendixes, or you can do one kidney. Like there are some organs that not that they're not complicated, not that they don't have their own important function in the body, but the heart is super important. So I love that you admitted that you guys weren't BFFs in the beginning. So that's good. I should ask you this. So I know that not everyone is a football fan, but I do love this tradition that Iowa has when you got to give people an idea of what happens at the football game and like the proximity of the children's hospital where you are in proximity to the university.
Yeah, I mean, smartly or not, the children's hospital is right across the street from our stadium where the Hawkeyes play. And so whenever there's a Hawkeyes game, everyone stops and then looks towards the children's hospital. And then there's what we call the wave. So the children and their families, the ones that have that availability, of course, are standing on the windows of the children's hospital across all the floors. And then everyone who is at the game just turns towards the hospital and takes a couple of minutes to wave at the kids that are there, recovering from illnesses and everything. So it is pretty neat. It is a little bit inconvenient, I will say, from a doctor's standpoint.
I was getting ready to ask. Yes.
Having to get to the hospital on a game day, I'm like, this was not the most well-designed thing, but the wave is pretty special and everyone loves it. So I guess we just cope with it. And I just get there before the game starts, and then I just stay there until the game ends. So I
Well,
just
you
figured
should
out a
be
way.
passing out like a flyers. Like if I love that you said that you fell in love with babies and pediatrics first, and then you fell in love with the heart. So I feel like that could be a good recruiting tool for if you love children and if you love babies, maybe you should consider medicine. So that feels like a good segue there. So okay, so let's talk about pediatric cardiology hemodynamics. So I think a lot of people are familiar with the role and function of a pediatric cardiologist, but how did you get interested in hemodynamics, and then what exactly is that for those of us that are not as well versed as you are?
That's a great question. pediatric cardiology evolved as a field primarily focused on congenital heart disease in the neonates, in the baby population, and rightfully so, because that's just so complicated, and it's a whole world of its own. Just to learn all the different defects that you can have and how to treat them and how to manage them before and after all the surgeries. So it became a specialty, very, very focused on that. And as a neonatologist, working in an intensive care setting, seeing babies that are sick every day, but who may not have congenital heart disease, meaning whose hearts have the right structure. They don't have abnormal holes or connected to different places that they shouldn't be connected. They are structurally normal, but they may not be working how we need them to work. And there was a little bit of a disconnect between what we would ask from when we needed an echo, when we needed a scan, and the information that we would get, which was very, very focused on the structure of the heart. Yeah, all the chambers are where they should be, the valves are where they should be, they look normal, and so on and so forth. But that's not what me as an intensivist with a sick baby need to know. I mean, obviously that is important, but that's a one-time information. And once I know that, I don't really need that anymore. What I need to know is, what are the pressures inside the chambers? How much blood flow is going through the valves? What is the pattern of flow that is coming back from the lungs or going towards the lungs? Because those are the type of informations that help me decide what medications does my baby need when they have hypotension, when they have low oxygen, when they have a murmur and things like that. So there was a little bit of a disconnect, historically, between what pediatric cardiology was mostly focused on and what neonatologists needed. And that's where hemodynamics kind of grew, because neonatologists just needed more information that it was just not there. Not because of anyone's fault. It's just that's not how the pediatric cardiology field had evolved. And at the same time, sometimes you have a baby who's very sick, you get an echo, you get a certain amount of information, you start a medication, and then the baby changes completely. And now you may have a different problem. And then people would call and say, well, can I get another echo? And they were like, why? I already told you there's no congenital heart disease. Why do you need another echo? Because that's just not their focus. And they were so busy with other things. So a group of several neonatologists around the world kind of created this specialty and this expertise where they partnered with pediatric cardiology to learn how to do the ultrasounds of the heart, to learn how to do those echoes, but in a way that was more focused on the function of the heart and not as much on the structure of the heart. That's not to say that we don't look at structure. We have to look at the structure. We have to make sure that all the things are connected where they should be. But we put a lot more focus on the pressure of the chambers, the velocity of the blood flow, how much blood is going through each part of the heart, and that sort of stuff. So that's how hemodynamics was created, and that's why I wanted to do it, because I wanted to know what exactly was going on so that I could choose what's the best medication that I can give that will actually target the main problem that is going inside of the baby, not just based on what are the numbers that I'm seeing on the outside.
No, this is fascinating. So our son had 2 heart defects. So as I'm listening to this, I'm thinking back to all the echoes that we had. And yes, we were super focused on the structure and where the valve is, and is this closing, and is this murmur going to get louder or softer? We used to call it a medical student murmur, which was good because that meant that the hole was getting smaller. But what I'm fascinated by is this movement of what's happening in the heart. So when you decide, okay, so a baby doesn't have a VSD or a PDA or any other heart defect, how do you, if you're looking at the function of it and it's not functioning well, how do you break that down? How do you decide, like, we need this medication or we need to try this? Like, give us some ideas of what you might encounter and how you sort of sort through what the right course of treatment is.
Yeah, so our echoes, and we call them targeted neonatal echoes, or TNEs for short, are echoes that have a multitude of parameters, because we can't rely on a single number on its own to make a decision. So for example, if I want to look at how the left side of the heart is squeezing, contracting, I have at least 3 or 4 different tools on my scan, throughout my scan, that provides me with quantitative ways to see if the muscle is squeezing how it should be, or if it's not squeezing properly. And that's important because every method that every measurement that we have on an echo has problems, right? Because it's not a perfect science. But if you have, 4 different parameters and they're all going in the same direction, you are more confident to say, yeah, that left heart is not really squeezing as it should be. So one example would be, let's say I have a baby in the NICU that has low blood pressure. And low blood pressure, if it's impacting the baby, can be caused in very simplistic ways, right? Very high level here is it could be either because the heart is not squeezing well, it's a problem directly inside the heart, and we're going to need a medication that is going to help the heart squeeze. Or it could be, for example, because the blood vessels across the entire body are actually kind of floppy. So they're not tight enough. But the heart is actually doing fine. So you can tell just by those 2 examples that the therapies that we would be giving would be very different, because one of them is directly targeted at the heart, the muscle of the heart. I want to make the heart squeeze a little bit stronger. Whereas on the other side, I'm going to use medications that are help the vessels throughout the entire body get a little bit tighter so that the blood pressure can then go up. So knowing if there is heart dysfunction on a baby that has low blood pressure is very important, because it will narrow down the therapeutic options that I have to treat that low blood pressure. So if I do an echo, the baby has low blood pressure, but everything about the heart looks normal, I will feel more confident that I should use a medication for the blood vessels and not for the heart function.
So, okay, this is fascinating to me. So now you're getting me excited about the heart. Okay, so if a child comes into the NICU and clinically they look fairly good, maybe you hear a murmur or something, so then you start to do this like, is there a heart defect? What would encourage a physician or a neonatologist or an intensivist to look at that baby and say, okay, structurally the heart looks good, but I think there's still something going on. I know you mentioned high blood pressure. Like, what might be some of the things that you might see at the bedside that you'd be like, hey, I don't know if this is a heart defect, like something's brewing, and maybe you don't even know it's related to the heart, but you're like, something's brewing here, and we need to do more advanced testing to look at what's going on. Like, how do you know that?
Yeah, one of the clear ones is low blood pressure. Another very, very common one that we have in the NICU is low oxygen in the blood, or needing high oxygen through whatever ventilator or whatever support the baby is on. So the baby should be breathing whatever air we are breathing. If all of a sudden the baby is needing 50% of oxygen and we don't have any other obvious reason, let's say it's not pneumonia, it's not lack of surfactant on their lungs. So it doesn't really add up. Could it be that the heart is actually having a problem, that the pressure in the vessels of the lungs are so high that the blood can't get there? And that's why the oxygen in the body is low. So doing an echo with all of these parameters is one of the things that can help us decide if we need to target the vessels in the lungs or actually continuing to work on the lung tissue itself and use ventilators and use medications for lung specific problems. But I will say that I think it's important for the audience to know that we know very well our boundaries. And if there is a high suspicion that the problem is in the structure of the heart, we will recommend that the first echo is done with pediatric cardiology, because that's their expertise. They are even better than us. We will pick it up if we got it wrong. But if the suspicion is really high that the problem is a structural problem, we will say, well, let's get a cardiology echo first. And then if they rule it out, then fine, let's us do the other measurements, and then let's treat it as a more functional problem. But if you're pretty certain that it's not a structural problem, either because baby had a fetal echo or because the clinical history and the symptoms don't really fit with a heart issue that is structural, then targeted neonatal echo with all of our parameters is pretty helpful in deciding therapies and other things.
So how prevalent is a hemodynamic specialty across children's hospitals? Do we have a plethora of people who are involved in hemodynamics, or is that an area where there's a lot of room for growth? Like, give me an idea of, if my baby doesn't have a structural issue with their heart, what's my access going to be like for a
This
hemodynamic
is
specialty?
very, very new. I
Okay.
was the first fellow to do this
Okay,
specialty
so
training in
very
the
new.
US.
Okay. Okay.
It's very new. So the first place to open a very formal program was the University of Iowa, which is where I trained. We are now in our 6th year, but we can only train 2 people every year, maybe 3. So it will be a while until you can have most of the big units across the country with access to this specialty. Of course, we have sent some around and they are training their own people, and there are other centers who have their own training programs, but it's still pretty uncommon. But that's not to say that even though you may not be able to get a targeted echo, or you may not have a hemodynamic specialist in your center, that doesn't mean that the knowledge is not being disseminated a little bit faster. So we have a lot of educational programs, and we are reaching out to a lot of units and helping neonatologists think the way that we do and interpret. Even if the information is more limited from their pediatric cardiologist echo, at least they have a different eye on how to look at those echoes and how to interpret, or even how to ask more questions to the people who are doing those scans.
So would you have a baby that has both? Like, how prevalent is it that you might have a baby who has structural issues, but unrelated to the structural issues, there may be hemodynamic issues? Is that possible, or would they
Yeah,
really kind of fall into 2 camps, one or the other?
it is possible, especially in the minor defects, so VSDs, ASD, PDA, and we actually treat a lot of those simultaneously. In fact, we mostly manage those babies in the NICU at the University of Iowa, but then once they go home, then they get their outpatient follow-up with pediatric cardiology. When it becomes a bigger or more significant structural heart defect, then it really is in the camp of pediatric cardiology, because our training is just not meant for that.
Sure.
And they know how to take care of that because that's what their specialty has focused on.
So if you're a NICU nurse at the bedside, what are some things that you're looking for if you're like, I think we need to call in the cardiology unit because we're seeing some things that are concerning. And then you start to figure out, is it structural or is it something else? So give me an idea of some of the things that they might be looking for at the bedside that might like bring some alarm bells out.
So low saturations, low blood pressure, a high heart rate, the baby's color not looking very good. So not a pink baby, a pink baby that looks a little pale or maybe almost grayish looking or bluish looking. A baby who's not peeing, you would expect. A baby whose labs are coming back abnormal, that they have too much acid in their blood or they have a high lactate. I think a murmur, obviously, on the exam. A baby who's huffing and puffing, but doesn't really have much lung disease on their X-ray. That should also raise suspicion for heart problems. I think those are probably the big ones.
So do you find that, I know you said that it's fairly new, so I know that, thinking about the number of people, you don't necessarily have people that are focused on hemodynamics around the country, but what's the relationship like between pediatric cardiology and pediatric cardiology with an emphasis in hemodynamics? Like, how would you work together to like co-treat a patient, or how would you sort of pass off care from one to the other? Give us an idea of how that might work.
Yeah, that's a very important aspect of the care, and it might be a little bit why this is relatively new. But it's important to have a good relationship, and we have a fantastic relationship with the pediatric cardiologists in our center. It's very symbiotic, and we know where our strengths are, and we know when to ask each other for help both ways. So not only we are the ones doing a hemodynamic assessment, and now all of a sudden I say, well, I found something that I wasn't expecting with the structure. Please help me out and come take care of this patient. But the other way around also happens. They might get called to rule out structural defect because of some antenatal concerns, or because of, people thought that that was the main problem. And then if they find that the structure is normal, but that there is something functional that may require an additional eye, they also request our help in return. So we work together. We tend to be very active in the NICU because in our center, if you have congenital heart disease or the big structural heart defects, you end up going to the cardiac intensive care unit. So we only take care of babies that have minor defects or that don't have any structural defects. So I would say that 80% of heart-related problems in our NICU are managed by us. But then these babies are going to go home. And if they need follow-up, then we need to have good conversation and a good relationship and a good understanding of the disease to communicate with our specialists in pediatric cardiologists, because they are the ones who are going to follow the babies once they go home.
That was going to be my next question. So let's talk a little bit about follow-up. So a baby is under your care. First of all, how important is follow-up? I think I know what you're going to say to that. But then what does that process look like, and what are you monitoring? What are you looking for?
Very important. The heart does not get fixed and stays well for the rest of your life. It's important to have follow-up, especially in a couple of populations. The traditional model is that, pediatric cardiologists will follow, but we are developing some programs for some very specific populations where both the pediatric cardiologists and one of the neonatal hemodynamic specialists will follow up these patients once they leave the NICU. And that's primarily babies who leave the NICU on medications that they're likely to stay on for months or years. So either medications that are to relax the blood vessels in the lungs because of pulmonary hypertension, or medications for blood pressure issues, usually high blood pressure issues, which a lot of our preemies do end up with that problem. And then depending on, obviously, on what their disease is, they will have a combination of echoes and blood pressure monitoring and some labs that are done in the outpatient setting. But most commonly, it's an echo and a follow-up, and making sure that we have that eye looking at the heart as well, and not just the lungs or the growth or whatever. I hope that answers your question.
It does. And I'm just thinking about, when our son was little, like doing those echoes were fairly easy in the sense that he was pretty easy to placate, to keep still, because that's important. But as he got older, it got super stressful. So if you can work on making echoes faster, but also just as accurate, I would greatly appreciate that. But I know it gets tricky because you want to assess the heart fully and have a really good picture. And it gets tricky as they get a little more obstinate in we were like super creative in pediatrics. Like you gotta work with them to figure out how to get the best results. But so let's talk a little bit about that. Like what would be the difference in treating, Dr. Bischoff, like a pediatric heart versus an adult heart? Because there's a lot of people as they get older that they go to their cardiologist, but the pediatric heart is unique and different. So kind of give us an idea of what that treatment looks like in pediatrics versus what it might look like in adults, to give people a sense of what's different.
Yeah. For the most part, the diseases that adults have are very different from the diseases that babies or children will have in their hearts. When we're talking about babies specifically, especially premature babies, we know, and we are learning more and more through research, that their hearts obviously came out too soon, right? And so they didn't develop to the full potential that they could have developed. And also, by all of the interventions that we have to do in the NICU to keep these babies alive and send them home, we may make that even worse in some sense. So the heart may be growing smaller, or the tissue may be stiffer. And that actually puts these babies not only at risk to having problems while they are babies in the NICU, but also in the long run. And again, this is all very new information. We're still learning so much about it, but we have some good evidence to say that babies who are born too early and who have what we call heart remodeling, meaning that the heart develops slightly stiffer or in a not quite the size that it should be, that these babies are going to have higher risk for the same diseases that we are treating in adult cardiology. So hypertension, heart failure, challenges with exercise, and so on and so forth. So I would say that obviously we want to treat and recognize any alterations that we have whenever we can. Granted, you can't make a heart grow bigger, but I can try to make sure, that that family is having counseling about all the things that will make a heart healthier, right? Exercise, diet, making sure that the blood pressure is good, and so on and so forth. But also making sure that that heart is going to develop to its best potential to prevent the complications later on. So we're much more in the preventative side of medicine because we want to make sure that we're not going to be saving all these babies, but then they're going to be 30-year-olds that can't run or can't exercise because now they have heart failure that developed too early, when really they only should have heart failure in their 70s. So I think we're much more in the preventative side of things in pediatrics. Obviously, there are diseases that we need to treat, arrhythmias and congenital heart defects and things that you might have to close holes and give diuretics and so on and so forth. But when it comes to structurally normal hearts, we want to make sure that we are treating things early enough, not because necessarily the baby is showing signs that it's bothering them now, but because we don't want that problem to make them sicker too early in life later on when they grow up.
Yeah, like you want to give them the best possible chance to have the most quote unquote normal development of an organ that they can. This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Hand to Hold is here to support your NICU in two ways. One, you can refer your NICU parents to us for support, or two, you can bring dedicated Hand to Hold support to your NICU, either in person or virtually. Our support consists of one-to-one group and educational resources, including our family-focused podcast, NICU Babies Parent Support. For more information, visit handtohold.org and click on NICU Professionals. It is fascinating to me, like when you were talking about, oh, we'll just close that hole, or we'll just, move this valve, like we'll just do all these things. It's fascinating to me, one, because in a neonate, that organ is so tiny compared to a human heart. So just the physicality of that is fascinating to me, but also like how you can absolutely improve the health and the long-term longevity of a patient just by, like, we went into the cath lab and closed his PDA, and I was like, that is fascinating to me that we just did this today, and so that part is exciting to me. So do you ever work, Dr. Bischoff, with patients who maybe the structure or the function of the heart was so dire that they found themselves on the transplant list and now they have a heart transplant, and now you have a baby who has a heart that was not originally their heart, and now you have different issues? How does that work when you have that particular patient and it's a whole new, like it opens up a whole new wing of, okay, now we have to monitor this in a very different way? What does that look like?
Yeah, I don't typically deal with that population because that falls more under the umbrella of pediatric cardiology. I have had patients in the NICU with myocarditis or with other problems that caused significant heart dysfunction that we just could not recover with our usual drugs, and that ended up being on the transplant list. But last that I checked, some of the babies that I actually knew that were on list for transplant were not really qualifying for it anymore. Over time, their hearts improved. They were still not normal, but they were improved enough that they actually didn't need transplant anymore. So I'm probably not the best person to answer the question about follow-up of patients who've had heart transplant, because that's just not the population that I typically treat.
Would you find, I mean, what, in the sense of, could they still have, not structural necessarily, but function of the heart? Like, how do you assess a heart in your, like, similar
Yeah, same
ways?
way, same way,
Okay,
same way. Yeah, we know
fascinating.
that they're more likely to have a couple of problems because of the immune system, and it's a tissue
Sure.
that is different and all of that. But the assessment and the evaluation is fairly similar.
I interviewed a mom, her son has HLHS, so hypoplastic left
Mhm.
heart syndrome, and received a heart transplant. And it's so fascinating to me because we're just normal moms. And then you give our kid, some challenge or some new diagnosis, and all of a sudden it's like we went to medical school. We become super fans of this particular organ, and you learn a lot about it. And it is fascinating to me, the things that they can do now that they couldn't do. Our son's 15 now. So things that we weren't doing in the NICU or even with specialists then, they're doing now. So maybe let's talk a little bit about that. Like, what are some things that are happening now that were not happening a few years ago that are really improving the outcomes of babies and their long term, like what life can look like for them long term?
I think one of them you just mentioned that your son had, which was the cath closure of the PDA. So for the audience, I don't know, do people know what a PDA is, or do I have to go through that?
maybe briefly, these are NICU professionals that are listening to this. Maybe give them just a brief overview, like what is a PDA? So yeah.
Yeah. So PDA is that little vessel that connects the aorta and the pulmonary artery when the baby is in the utero. And then once the baby's born, it should go away. But especially babies who are born premature, the vessel may not go away. And the problem when it stays open is that it sends too much blood to the lungs and it doesn't send enough blood to the rest of the body. So when we try to close it with medications or other strategies and that doesn't really work, then some doctors may say that, well, we should get rid of this thing. And it used to be that 10 years ago, 15 years ago, the only way to definitively deal with a PDA was through open heart surgery. That doesn't mean that the baby would have to go on bypass or on the pump, but they did have to open the chest, spread out the ribs, find the PDA, put a clip on the outside, and call it a day. And the surgeons were really good at it. Even that really, really tiny babies, I mean, they still do it. They're awesome at it. But it is invasive, right? You're opening sometimes a baby who is 900 grams, 500 grams through a surgery. It's kind of a big deal. And then through, advancements in technology and the field kind of embracing this, they've developed these devices where you can go through inside of a vein, right? Usually you go through the groin. They go put a catheter where they can see on an x-ray where that catheter is going. At the tip of that catheter, there's a little device and it looks like a little umbrella. They just kind of pop it inside the vessel. And it's like a cork. It basically interrupts the blood flow and the vessel kind of scars around it and it's done. It's gone. It probably takes much longer to mobilize the patient to the cath lab and do the anesthetics and everything than the procedure itself. The procedure itself takes about 10 minutes. And the fact that they are doing this in such a precise way with devices that are so small that they can fit into the smallest preemies, and in a very safe and fast way, is definitely one of the big advancements in technology of the field, and that has changed the trajectory of a lot of babies. It's a faster procedure. The recovery is faster. There's still things that we need to monitor, but it tends to be much simpler than the traditional surgical ligation. And we are doing it in smaller and smaller babies. And in some centers, not at the University of Iowa yet, but in some centers, they're not even taking the babies out of the NICU. They're just doing it with ultrasound guidance, which is pretty awesome. I've visited units who do that, and I think that will be the future. So you're not even exposing them to radiation or anything like that. That's pretty unique.
Well, and just the mere fact that our stay was literally, it was a day surgery. We went in that morning, we did the procedure, we left that afternoon, obviously, monitoring, making sure that everything looks good. And had that been open heart surgery, that would have been a multi-day hospital stay in addition to the care afterwards. And let's not talk about all the infections that could or could not have happened because you're opening up a baby in a pretty significant way. So to me, it's absolutely fascinating. And then the VSD closed on its own. I was like, praise the Lord, we did not have to do surgery for that. But I find that in 15 years, so much has happened. And I don't think I really recognized 15 years ago, maybe how monumental that was that we could do that. I just thought that's the way you did it because that's the way that we were presented. That's just the way our hospital did it. And as I talk to more and more patients, they're like, oh yeah, that was not our experience. So what's on the horizon, Dr. Bischoff, of what are we thinking about, oh, we're close, we could improve outcomes this way, or when we figure this out, this is what's next. What's sort of on the horizon that y'all are thinking about and dreaming about as to what may happen in heart care for neonates?
I think one of the big ones, and it's funny, I was at a conference this past weekend and someone said in the audience, we can't just talk about medicine these days without bringing the word AI, but it's true. And
it's true.
I think one of the things that a lot of people are focused on developing is how we can take advantage of the computers and the predictive models to incorporate into how we take care of patients. So how can we teach a computer to analyze all these echo numbers that I'm getting in a patient and combine that with all the very granular vital sign data that they are gathering already minute by minute and try to anticipate when is a baby more likely to have a cardiac arrest, or when is a baby more likely to have a PDA that is open and that is causing trouble and that might need treatment. It's not going to substitute the doctors and the critical thinking, but I think AI is going to help us to create some triggers for us to identify problems a little bit sooner than what we would have done if it was just based on the human eye. And so I think it might be, I mean, I hope that one day it will be like, oh, look, the computer put all of these parameters together and it's giving you a score saying, maybe you should get an echo because the combination of these things tend to precede the development of significant heart dysfunction or of a significant PDA or whatever it may be. So I think AI is definitely a big one. Other advancements are just the ongoing advancements in neonatal care in general, not just specific to the heart, but devices that are meant for progressively smaller babies, right? We are taking care very routinely of babies that are born 22 weeks, who are really, really tiny. Sometimes they're not only tiny because they were 22 weeks, but they were also not growing very well. And we just need to keep up with them because we know that we can treat their physiology. So we need the equipment to also fit into all of them so that we can actually treat them. And I hope that there will be ongoing efforts from all the companies who do medical equipment to tailor them to this population.
I was just visiting a few episodes ago. I was visiting with a professor at Notre Dame who's been working on the designs of NICUs. And he said the very same thing that you did about AI in the sense that the machines don't necessarily do our jobs for us, but the input that they give us sort of reduces the trauma and the invasiveness of all the tests that we have to do. So that then instead of us figuring out like when the alarm bell goes off, instead we sort of know that it's coming and then we can readjust. Or I was visiting with a ophthalmologist the other day and she was talking about, sometimes if we give them too much oxygen, it increases their ability or their propensity to have ROP. But if we can reduce that, but also preserve the eye. And so all of those things are exciting to me as a NICU mom to know that instead of being so reactive, you're a lot more proactive and a lot what it allows you to do. I actually told Dr. White this. I said it feels like you're able to be a better doctor because some of the things that bogged you down before the machines are doing, and now you can actually practice medicine. So I don't know if that's how you feel, but I was fascinated to learn that part of it.
Yeah.
So let's talk a little bit about this integration of hemodynamics. So if you are at the bedside, you have a baby that you think, hey, we definitely have a consult from pediatric cardiology. We don't have someone who specializes in hemodynamics either at our hospital or at the bedside, but we think it may be more of a function of the heart and not the structure. What do you do? How do you help that baby?
You still help them the same way. I think you just have to ask the right questions. If the echo that the neonatologist requested didn't quite answer the question that they had, but they still have a suspicion, I think they can always have open communication with the people from the echo lab and say, hey, look, I know that you guys told me that, the structure was normal, but my baby is doing X, Y, and Z. I'm wondering if there's a problem with the contractility or with whatever, so that they can maybe pay a closer attention to that aspect. Because what frequently happens is that, there's a disconnect between the people at the bedside and the people performing the test, right? Frequently, the neonatologist will order the echo, may not put that much information on that request to begin with. And then there's an echo tech that comes to the bedside that knows nothing about the baby, does the echo, and then brings it back to the echo lab. And then there's a pediatric cardiologist there who's just sitting down. He just looks through the images and he reports what he would usually report. But he sometimes does not know what's happening to the patient that was scanned in the first place. So having open communication to be able to call the echo lab and say, hey, I saw that you read this echo that you did because my baby is doing X, Y, and Z. Do you think it could be because of this problem based on what you were seeing? And even if they don't have all the measurements or all the tools that we use in hemodynamics, they may be able to pay a closer attention or give it another eye to it to try to help out the neonatologist in how to treat or not to treat the patient.
Well, and it also brings home the point that family-centered care. I know we received that at the second NICU that we were at. So we were in a bay in the first hospital, and then in the second one, he was critical. And so we were in a situation where we had all these people who are rounding, and so everyone was hearing, from me, the mom, but we were also hearing from all the other specialists. So it sort of took away that bad communication effort in the sense that we were all rounding and they were hearing all the things at the same time. And then I would, lobby, I would be like, well, instead of doing this, can we try this? And then, one may say, oh, well, maybe we can. And another would. So it was great in real time to have everyone on the same, which I think is sort of what you were alluding to, is that we have this opportunity to maybe share information better so that
Yeah.
whenever we make decisions, the outcomes are better. So
And I'm not trying to advocate here that all the echoes are incomplete or they're not
sure,
going to
sure,
answer
sure.
the
Oh yeah.
information. They might, right? Depends on where you are and how you request that information. But I'm saying that if the person taking care of the baby or if the parents are still concerned, then they should at least ask, are you
Yes.
sure that it doesn't, even though all the chambers are where they should be and there's no additional holes and whatnot, are we sure? Have we looked to make sure that it's not a problem with the function of the heart or with the muscles or whatever? And they might say, oh yeah, we looked and it was fine. Then you move on, right? But at least having the openness to ask those questions, I think it's important both for parents and for the primary care team.
And I think that's something that you learn over time. Like when we first got to the hospital, I was like, I'm asking no questions because I have no idea what's happening. But the longer that you stay and the longer that you're around all the specialists and the longer that you hear everything, you think, well, maybe I should speak up. And I think that's not just for parents, but that's for NICU nurses or for anyone that's around the bedside. Like when you start to get to know the patient, like there's one thing that you can see on the paper, but then you're looking at them clinically and you're like, but what we're seeing on the paper, or even maybe they're looking even better than what the paper says. So we have to look at this baby, like we got to communicate. So I do think it encourages us to treat the whole patient and not just like what we see on the echo or just what this test says, like clinically, what does this baby look like and how can we help them be better? All right, so I want to talk about some of the challenges that you may have, like in hemodynamic. Why is that so hard for me to say? I'm going to say it's my Texas accent in hemodynamics. So, what might be some of the challenges that you might deal with, whether it's in treatment or whether it's in identifying what's going on with a baby? Like, what are some things that you encounter that you're like, these are some challenges that we have, and if we can overcome this, we could do even better?
One of the most basic problems that just popped to my head as soon as we were asking that question is the ability of the ultrasound machines. Some babies just don't have good images. Like they don't. Frequently, if they have a lot of lung disease, the preemies that have BPD, sometimes the ultrasound is just not good enough to see the whole heart or to get all the measurements that we want. And sometimes the echoes have to be kind of limited, which takes away a lot of what I'm proposing that is important, right? Which is the multi-parametric approach, which is doing all these measurements to see the trajectory and to see what's happening. And sometimes I'm like, ooh, I can't really get all my 80 images. I'm only going to get 20. So that's a problem in not a lot of babies, thankfully. And we are getting better and better at doing those ultrasounds and being savvy about how to image the heart. But sometimes it's just beyond our capabilities. And I think, and I hope that in the future, there will be other imaging modalities for those challenging cases. One of them that is coming up quite a bit, and I hope that we will develop more for the neonatal population, is the use of cardiac MRI. Because cardiac MRI, it doesn't matter what your lungs are around, you will be able to see the heart. But obviously, there's a lot of work that still needs to be done on how to put the babies on the scanner and where are the scanners in the hospital, and is it really worth mobilizing the patient? But I think that will be a future for a couple of patients and some populations where the ultrasound is just not good enough. Let me see other challenges. I mean, sometimes the diseases don't sometimes I would say more than just sometimes, frequently, the diseases don't fall into simple buckets, It's not like it's either
This is why
A
you're the
or it's
doctor.
B.
This is why you study this. We need you. So
Yes.
yes.
Sometimes they go like this. Sometimes they kind of
Yeah.
intersect with each other. And it's like, well, if it was just A, I would give this therapy. But because
Mhm.
there's a little bit of B, by doing this therapy, I might be making this part worse. So sometimes it's a little bit like being on a scale and trying to titrate so that you don't make A or B worse because they are kind of overlapping with each other. And there's a little bit of an art to that. One of the common ones that falls into that are patients that have pulmonary hypertension because of elevated resistance. So those vessels in the lungs being really tight, But at the same time, they have a hole, like a VSD or a PDA or an ASD. And so if I use a medication that drops the resistance too much, then I get more blood going through that VSD, and then the lungs get flooded. And if I don't use, then I get too much pulmonary hypertension, and then the oxygen increases, and so on and so forth. So there's a little bit of an art in how to maneuver that, and it's not always easy. I will just say that. But having echoes and having those parameters and those numbers does help with the precision of how to titrate the medications, because at least we have some quantitative ways to say, okay, this part is getting better by this much. Well, 2 weeks from now, oh, well, this number went up or this number went down. And that kind of helps us out, I would say.
So is hypertension something that you see more often than not when it comes to the function, or is it, yeah?
Yeah, pulmonary hypertension is pretty common in neonates, but we are also seeing more and more babies with systemic hypertension, just like adults that have high blood pressure. Probably because they're surviving more, they're using a lot of steroids, their vessels, again, just like the heart, didn't develop quite well. But it tends to be a somewhat unrecognized problem in the NICU, because if the nurses are doing the blood pressure and they get a high number, they'll say, well, the baby was fussy, and the baby was angry when I was doing it, and that's why it was high. And then they keep doing it until they get a normal number, and that's the one that gets charted. So it might go unrecognized because we have that bias to say, well, this is not really a baby problem. If I got an abnormal number, it's probably my fault or the baby's fault. It's not really a disease. But the more and more we look at it, we're like, no, there's some babies who, even when they're calm and you're getting the blood pressure the right way, that number is still too high. And we should probably pay attention to that so that the heart doesn't suffer pumping against that high pressure all the time.
That's interesting that you mentioned that, because sometimes I feel like a lot, and I don't say this to pick on NICU nurses, but sometimes we think, oh, if we did that test, it was because they were agitated. I mean, we know that the NICU is a hard place, no matter what, whether you're the doctor, the nurse, the patient, or the parent, or the caregiver. It is a hard place to be. So sometimes I think you're right. We may humanly dismiss something like, oh, they were agitated, or oh, I was running through, like we had a bunch of tests to do, and this was like the last one. That you think, okay, maybe I need to step back and be like, maybe that reading was actually correct, and maybe I need to alert someone. So let's talk about bias for a little sec for a quick second, not just in that, but like, do you find, or I guess, how do you counteract patients that maybe are in a population that taking care of their hearts is not something that they do, or maybe they don't have the education? Like, how do you make sure that the care of the babies isn't sort of being impacted by some of those either disparities in healthcare or implicit bias or all those other things, that baby's heart is cared for the way it should be cared for?
That's an impossible question to answer. I don't know how you handle that other than through continuing to educate everyone, not just the doctors who are taking care of these babies in all the different units, but the nurses, the respiratory therapists, the nurse practitioners, and the parents, because the parents can ask questions. And it's really hard to just dismiss the parents if they keep asking the same thing. So the doctor is going to have to go back to get that answer. And I found it really helpful, like I said, to do education in the multidisciplinary team, because even if my colleagues, that when they didn't know the specialty very well, they were like, well, we don't really know how this is helpful, or do we really need it? But if the nurses were getting educated and they were seeing how I was practicing, now that I had this technique, now that I had these tools, they would pass on that message. They would say, well, but there was a case that was very similar to this. We did the echo, and this is what it showed. We wouldn't have known if we didn't do the echo, so perhaps we should consider, so that they can advocate as well for the patient. So I think that's the main message, is just continuing to educate and raise awareness for everyone, so that we are asking questions and learning about this.
I love that you mentioned that. I was talking to a dad the other day. His son has a rare disease, and he was saying that their nurse that was taking care of them, it was so rare, and it was troublesome because they didn't find out what it was until many months later. But then another baby came in, not too long after they did. And she immediately recognized, hey, I've seen this before, and spoke up for that baby. They intervened, and it made a massive difference in the outcome of that baby because she had seen that in another patient and decided to speak up. So I love that reminder that you get these experiences. I mean, we've talked to other parents, we've talked to other specialists, and they see something in one patient. And while it may take, it took us 7 months to figure out that our son had a blood allergy to cephalosporin-based drugs. But now that we knew that, then our hematologist was like, man, I diagnosed a ton of kids because I saw it in him first. And then we were able to see it in other patients quicker because my eyes were like a little bit open to something that maybe everybody else passed off is no big deal.
Definitely. And even with other specialties, right? Sometimes we do a lot of education with, the pediatric surgeons, with the palliative care group, and all other specialties, pulmonology, neurology, everyone that kind of goes through the NICU and takes care of babies. We try to do some education that is pertinent to that area because we're all part of the same team, and our organs will intersect. The heart is sending blood to all of them. So we need to know how to work with each other and understand how our therapies may be impacting on them as well, and vice versa. So just education.
So speaking of that, what's like one misunderstood thing that you think people have sort of a perception about pediatric hemodynamics? Are they like, you're like, if only they knew this about what we do, that would be super helpful?
First, I don't think it's a specialty that many people know it exists to begin with. And because they hear the term hemodynamics, I think there's a misunderstanding that hemodynamics is kind of like adult hemodynamics, and adult hemodynamics typically is referred to cath lab type of people who do tests in the cath lab, measuring the pressures and whatnot inside adult hearts. That's not what neonatal hemodynamics is. Neonatal hemodynamics are neonatologists who did 1 year of training to learn how to do echocardiograms of the heart and learn how to treat heart and vessel diseases in a more precise way by combining their intensive care expertise with pharmacology and physiology information that they obtain from these images. So it's very different from the adult hemodynamics, I would say.
See, you are a super fan of the heart. You just didn't know that you were going to be such a super fan all this years ago. Well, Dr. Bischoff, thank you that was fascinating. I was a little worried because I was like, I know enough to be dangerous about the heart, but I love that. Thank you for describing what the difference is between the two, but also how they commingle and how they work together, which is ultimately the goal in the NICU, is that everybody works together. And the end result is a neonate that has the best possible life they can based on some good intervention, but also a lot of love in the NICU and all the specialists that take care of them. So thank you for being such an awesome guest. I appreciate it.
Thank you for inviting me. I just want to raise awareness, and I want people to know that this exists and that we are learning and paying attention to the heart in new ways that hopefully are going to continue to improve the outcomes for our babies.
Thanks, y'all, so much for listening. That was a fantastic conversation. I hope that you'll do me a favor. If you love today's episode, please share it with a friend. You can also review over on Apple Podcast or Spotify or wherever it is that you listen to podcasts. You can also give us a listen and a watch over on YouTube. It's how we reach more NICU professionals. Today's podcast episode is sponsored by Reckitt Mead Johnson, whose mission is to nourish the world's children for the best start in life. For more than a century, they have led the way in developing safe, high-quality, innovative nutrition products and continue to push the boundaries of nutritional knowledge with consistent, strong investments in scientific exploration.